Well, good afternoon, everybody. This is Jim McGuire with VITA. Thank you for joining another VITA Learning webinar. Today we're going to have Dr. Julian Conejo go over aesthetic case management to optimize the smile result in all ceramic restorations. There's a couple things. Hi, Julian. I hope everyone can see you. If you want to wave to the audience, that'd be great. So we're going to start in a few minutes. There are a couple house cleaning items I want to bring up first. So the first thing is that your phone, all of your phones are going to be on mute for this during this webinar. However, on the panel that pops out on your right-hand side of your screen, there is a question box that you can use and type in your questions, send them through. If it's something that seems that we should answer right then at that time, I'll go ahead and kind of interrupt Dr. Conejo during his presentation and give him a heads up. Otherwise, at the end of the program, we are going to have a Q&A. So make sure you use that question box if you have any questions at all. We are also recording this. This is a recorded webinar, so make sure that if you have time, you can later come visit our VITA website, learning videos and webinars, and you'll be able to kind of revisit, almost like wine. If it's great wine, you'll come and revisit us and watch Dr. Conejo go through this presentation again. At the CE, those of you who want to have CE at the end of the webinar, you are going to receive an email from our VITA educational site in which you will have to reply to and request that CE, maybe answer a few questions so that we can legitimately provide you with those CE. You can also learn more about anything about teeth, about ceramics, CAD/CAM, and so forth on our website through Facebook or through YouTube. We got plenty of videos that are also taped, along with these webinars that we do almost every week. So again, Facebook, Instagram, LinkedIn, and then of course YouTube, you can find all of these webinars and videos as well. So what we're going to do is we're going to go ahead and start with Dr. Julian Conejo. Again, aesthetic case management to optimize the smile result of all ceramic restorations. Dr. Conejo is actually, came to us from Costa Rica, graduated down in Costa Rica back in 2005, and became a prosthodontist as well. So Dr. Conejo's got a vast knowledge, across-the-board knowledge of crown and bridge, dentures. He's working with digital dentures as well. He resides at UPenn University currently. And he's a visiting scholar of the preventative and restorative sciences of UPenn, and he's someone that we often use as to bounce ideas with, and have him do some beta testing with us as well. And then he practices as a clinical dentist. So he's not just a university type guy, right? Dr. Conejo also is a wet dentist. So many of the questions you might have might involve clinical procedures, so please send those through that question box. And then from his research experience, he's written several peer-reviewed articles and studies. So I will turn this over to Dr. Julian Conejo. And Julian, you are now as the presenter, so go ahead and bring up your PowerPoint and we'll get started. Thank you, Julian, for joining us.
Yeah, absolutely. Show my screen. Okay, so Jim, thanks a lot for the introduction and of course for the invitation. For me, it's always a real privilege to be part of VITA North America learning program. And today, it's pretty exciting to be able to share with colleagues on the aesthetic case management. It's something easy to say. It's something very common, but we know that there's a lot of small things that can not be in our side in many clinical situations. Today we want to focus on on the interaction between the clinician and the lab, making sure that we get also the ceramists, the lab technicians involved. As much as we go in the digital environment, these communications still, I think it's very important. So that's basically what I would like to talk during the next hour. Please feel free to place the questions, and Jim, as always, if you need to interrupt me, please do so, or at the end we can make the Q&A and discussion as we've done in the past. Okay, so as Jim was saying, I actually work now at the University of Pennsylvania School of Dental Medicine as a clinical CAD/CAM director, and I've been using chairside CAD/CAM dentistry for 11 years now. And as a prosthodontist, I really like the possibility of being ready whenever I know that I can send this patient home with the final restoration, but as well, having this background, spend many years in a dental laboratory. My parents own a clinic and a lab in Costa Rica, and since I finished my residency, I've always been involved in the lab side as well. I understand that many clinical situations that perhaps are on a medium to a high complexity level, same day chairside workflow might not be the best for the patient. And that's something that I always try to remind myself, make sure that I focus on the patient's benefit. If it's something that I want to delay it and do a 2 or 3 appointment session, like more of a conventional approach, partner with one of the great ceramists and dental technicians, that might be the best for that clinical situation. So having that balance and making the call between chairside and partnering with a lab and a ceramist, I think it's so important. And the bad thing is that we don't see it happening as much as I would like to. Many times I see clinicians maybe rushing and trying to just do everything same day, chairside, and it's not so easy when we talk about these more high aesthetic complex situations. So this is a photo of the main clinic at Penn Dental Medicine, where I work with our students and residents, and it's really nice to have established these different protocols. Many times, single units, we do it same day. If it's a straightforward case with multiple restorations, perhaps nothing to match to, then we can do it as well more with a chairside approach. But also we work and partner with excellent labs and ceramists, and that's what I would like to emphasize today's content. I'm part of this team, the Digital Innovation Initiative, and we basically work hard every day to try to integrate all these new technologies. As Jim was saying, not only for the education and research world, but really to put it into the practice in a safe environment for our patients and providing good and sound, healthy research for the dental laboratories and technicians for the better use of our ceramic material. So we work with this concept in mind, always trying to make Penn Dental Medicine a global leader. So that's basically the part of the team that I am. As I always mention, it's an honor for me to work with Dr. Marcus Blatz, who is our chairman at the Department of Preventive and Restorative Sciences. And having now almost 6 years being with Dr. Blatz, with all the knowledge that he has on ceramics and what I can share from my past experience with chairside CAD/CAM dentistry, we have a very nice setup, trying to keep that balance. Always what is best for the patient, that's the workflow that we select, not what is going to be faster or let's say more beneficial in the economic side, which is also important, but we don't want to be driven by technology. We want to make sure that we use technology for our clinical concepts and decisions. So we're excited also to soon be having CE courses and congresses live in person. So stay tuned. We'll be sharing those informations very, very soon. Okay, so here we work with different types of ceramics, from hybrid ceramics, from feldspathic ceramics with lithium disilicates, and of course zirconia. And as I said, sometimes we send these scans out and work with excellent lab technicians. I think that Nowadays, having a ceramist, a lab technician, a dental laboratory that speaks your same language within the digital dentistry world and setup, it's very important. So we have this chapter talking about the current states of chairside digital dentistry and materials. And today I want to focus on some of the materials, not so much on the chairside approach, but more on what we call the Connect workflow. And this is the workflow that we use for these high aesthetic clinical situations, maybe more demanding patients. Many times we're remaking dentistry and we got to make sure that this result is better what the patient had in their first experience. So basically today, I don't believe in not doing a digital impression. That's the only type of impressions that I make. And then, of course, having a quality control of what I make the digital impressions with, and then send it to these different labs and having the expert do what they are better at. I think that's what makes a really nice combination. Nowadays, we have so many different types of intraoral scanners that whatever case we have, we can just go for an intraoral scan, and it's so easy to share it with different technicians wherever they are in your state, in other state, in other country, in other continent. So this really opens the number of possibilities with the people that we can start working together and collaborating, and that's something very, very exciting for us. So years ago, we published this paper trying to refresh and update the classification of dental materials. And today, my main goal is to show you a new material that VITA has, which is the VITA Ambria. But I would like to go at least through some of the important groups of ceramics that we have, kind of to understand exactly where this new material fits and where can we start using it in the best clinical situation. So as a quick summary, probably if you heard my lectures before, I always have this slide where we divide the ceramic materials in three main groups. On the left, we have the resin matrix ceramics, which is everything containing a percentage of resin. Okay. Then in the middle, we have the silicate ceramic group, which comes from the most traditional materials like feldspathic ceramic, which is one of my favorites. And then as the lithium silicate ceramics has started to grow and evolve, we have always new players in this group and team. And then on the right side, what I call the heavyweights, the oxides, mainly the zirconium oxide that we use nowadays. And we are working on making another webinar focused on zirconia. So that won't be my topic today. We're going to make a full session on zirconia, how to make sure that we optimize that material. So today we'll be talking about silicate ceramics and more specifically about the lithium silicate ceramic group. So as I was saying very quickly, the resin matrix ceramics, just as an overview, I talked last webinar on this, but we have VITA Dynamic, which is the only hybrid ceramic, because actually we have a block of feldspathic porcelain that is infiltrated with 14% of composite, making it less brittle and providing better machinability, which is something really nice for us clinicians when we do chairside CAD/CAM dentistry, because it mills very fast and very nice marginal adaptations. It has a great dimensional stability because what you mill is what you get. You don't place it in any type of furnace for any type of process. And it has a modulus of elasticity very close to nature, between dentin and enamel, around 30 gigapascals. And of course, these materials are not very strong in nature, so they rely on two things. They rely on minimal thickness and also on adhesive cementation. For these type of materials like VITA Dynamic or feldspathic ceramics, that are materials that need to go through bonding adhesive cementation process, that's a key factor for the long-term clinical success. So always keep 1.5 in the area of the cuspids when you want to use this type of hybrid ceramic, and you can see the milling is flawless. I really like to use this for inlays, for inlay onlay, for partial coverage restoration. As we all know, it's not so easy to obtain a passive fit in this type of more intracoronal restoration. So this is just a quick review of some of the research we've done as well on the bonding, and we know that this hybrid ceramic needs hydrofluoric acid etching for 1 minute to create that nice micromechanical retention, and then by applying a xylene coupling agent, then we can combine both micromechanical and chemical bonding, which are very important for the long-term success of the hybrid ceramics. Okay, so after etching, we will clean, and then we'll apply the xylene coupling agent, and this basically makes the ceramic surface more reactive to this xylene. There's more area because it's irregular. We basically remove the glassy matrix with that minute of hydrofluoric acid etching. Okay, so I'm just leaving that now as a quick introduction of the first group of materials that we have. And then today I want to focus on silicate ceramics. So everything that we see on the left side are very old, traditional, but high aesthetic materials. Okay, and I've always been a fan of feldspathic ceramics. The VITA Trilux Forte block, without a doubt, is one of my favorites when it comes to anterior restorations. And it's a material that, as a clinician, as a prosthodontist, I feel very confident using it because it's easy to finish. Why? Because we have this block in a multichromatic approach, and then we can always work on an external staining and glazing, and with the inherited translucency of the material plus the polychromacity of the VITA Trilux block, then what I need to customize is very minimum, mostly the incisal edge, and then we can obtain very nice clinical outcomes. What I said before, feldspathic ceramics, are they technique sensitive? I would say yes, but in general, everything that we do is technique sensitive. So creating that balance of having the minimal or appropriate thickness for the feldspathic ceramic, but maintaining the preparation as conservative as possible, focusing on creating space where space is needed and not over prepping where we don't need to create more space, that will provide us more enamel surface and also better long-term adhesive restoration. So this is our conventional workflow, always making dental facial driven mock-up. Once we have the mock-up, we scan the mock-up if we need any small modifications or fine-tuning in the patient's mouth, and then we go ahead and use the mock-up as a prep guide, and with our burr block, the 0.3 depth cutting burr, that assures me that I can create that minimal thickness but also maintain the enamel. So when we use such a high translucent material like feldspathic ceramic, the color of the abutment tooth is very important to consider. So in this case, you can see that the color of the tooth, once it's been prepped, the prep is very minimum. Sometimes these cases, you don't even need much anesthetic, or they don't even need much provisionalization if it's just for a few hours or 1 or 2 days. But when we use high translucent ceramics like VITA Trilux Forte, we need to evaluate the color of the abutment and be critical about it. Because if we are expecting to change, for example, from a A4 to a B1 with a very thin veneer of 0.5 or less, we won't be able to do that with a feldspathic ceramic because it's too translucent. Okay, so this opens the door of possibilities to the materials that we're going to talk later today when we have those type of necessities, when we need to modify more abruptly the color of the final restoration compared to the patient's initial situation. But when you have, let's say, a nice shade of the teeth to start with, or a a moderate color on your abutment, these feldspathic ceramics are really, really nice because they have the highest content of glassy matrix. Remember that what we are able to see is the value, the grayscales, right? So for me, making sure that I nail the value, that I'm accurate on selecting the shade, it's one of the most important aspects. So I evaluate the color of the abutment, I do my shade selection before I start the appointment, but also do a second session of shade selection once I finish the preps. And here I want to make sure that the value, the gray scale, how bright or how dark am I selecting the material, is something that I'm going to be able to reproduce. So this is just a screenshot of the VITA Trilux Forte, and what you can see are those 4 layers of different tones being much more chromatic or saturated towards the cervical and more translucent towards the incisal. Lately, the tools and the softwares have improved, so we have more freedom to play with the block and try to make something very personalized, even though it's a milled restoration. Okay, so there are different types of glaze and stains that VITA offers, and I always discuss with Jim that I like this more natural surface texture. I think that if you evaluate the restorations that you see in your patient's mouth, the ceramic restorations are most of the time much more glazed and polished and fake looking than the natural teeth. So I found that this material, the Accent Plus finishing agent, gives you that really nice effect of a final natural glaze without losing the texture, which for me is something very important when we are trying to reproduce natural teeth. So as I said before, with the V-Dynamic hybrid ceramic, basically it was a feldspathic block with infiltration of composite. We needed to etch with hydrofluoric acid etching for 1 minute, and of course that's the same treatment that we need for the feldspathic ceramics. Okay, so hydrofluoric acid etching for 1 minute. We need 1 minute to make sure that we remove that high glassy content to have those crystals exposed, as I said before. So when we apply the xylene coupling agent, we have a more reactive surface, more irregular surface, and then we can combine the best of both worlds for adhesive cementation, which is a micromechanical interlocking and the chemical bonding through the use of these xylene coupling agents. Okay, so once we do the hydrofluoric acid etching, we are going to clean it very well in the ultrasonic, or we can also use phosphoric acid, which is another simple tool to clean any residues in the intaglio surface of the feldspathic ceramic when we do the hydrofluoric acid etching step. And then once we place the ceramic primer plus or the conventional xylene, that restoration cannot get wet or contaminated at all. And then we focus on the treatment on the side of the tooth with total edge when we're in enamel, always trying to place an adhesive on the surface of the tooth, and then go ahead and do the adhesive cementation. If you see these photos, you see that the rubber dam isolation is making me able to create a very nice and controlled environment for the adhesive cementation process. So I'm saying that feldspathic ceramics rely on this step. That's why that's so important. And as I said before, we have a nice design, a nice biocopy from the mock-up, and we use this type of VITA Accent Plus glaze, we can have a nice surface, but also maintain that texture. That is something that creates a very nice and natural outcome for the restorations. Okay, so yes, the things that we gotta pay a lot of attention always is the soft tissues, how gentle we are when we place the first cord, and if we need to place a second retraction cord, not leave it more than necessary, because we are not sure which of those biotypes are going to have an irreversible recession. Okay, so I try to place a 000 retraction cord, finish my margin with that, and if there's any areas that I need a second cord, I pack it, and as soon as I'm ready, take them out and make my intraoral scan to reduce any possibilities of irreversible soft tissue retraction. Okay, so that's a typical case I do with a CEREC system. Any chairside CAD/CAM system, you'll be able to do that. And now I want to share a case where I understand that as a prosthodontist, as a clinician, even though I like the lab, I don't have the ability and the knowledge to solve the cases. And we published this in Quintessence of Dental Technology last year, and that's also a collaboration with some of the dental technicians that we have at Penn Dental Medicine, like Michael Bergler, who directs the CAD/CAM Ceramic CAD/CAM Center, and Suan, who works with me in the Digital Design and Milling Center, more focused on the chairside environment. So it's nice to have that team and go through the cases and understanding our limitations as clinicians. So when we talk about high aesthetics, we got to make sure that everything is facially driven. So we make this quick protocol of 3 photos, one in a smile from the frontal view, making sure that we can see the incisal edges of the maxillary arch. Then we take the same photo, but from a lateral view, and then from the 12 o'clock from top to bottom, so we can see the anterior-posterior relation of those teeth with the lip curvature on smile. So this is a very challenging situation for me. Young patient, close to graduate from Penn. He goes to us there, and he doesn't like 2 things. One, that over-contoured crown on number 9, and the diastema. But if we don't go through this analysis here, we use the DSD app, we are not really sure if what we can do is going to be something that will meet the patient's expectations. So the DSD app is one of multiple possibilities to do quick treatment plan sessions for these anterior cases, because one of the most important things in anterior aesthetics is space distribution. So we go through that process in every single case, and then we go on shade selection. So here, when we're trying to replace one existing crown and a central incisor, when we are discussing about involving contralateral tooth for closing that diastema, having ideal tooth proportion, length or width, this involves also a key factor for success, which is the appropriate final shade of the restoration. So for these anterior cases, I also like to use the VITA Easy Shade. The VITA Easy Shade is a spectrophotometer with significant scientific evidence that proves that we're going to get a very high percentage of success rate while selecting the shade. I'm not saying that I rely every single clinical situation on the easy shade only, and I don't work and try to become better on shade selection. I try to do both, but without a doubt, the technology is very, very helpful for those cases that perhaps my eye, my experience, my intuition is not so obvious of what type of ceramic block or shade for the restoration I want. So here, the cool thing is that we can download the Mobile Assist app, and then when I do the measurement with the easy shade, I'm going to take the photos, and then I can merge the information from the easy shade on top of the photo, and this is what I share with the team for the elaboration of the final restoration. So in these cases, we understand that central incisors are very symmetric. They are next to each other, and they need to be very similar. So we prep very conservatively a veneer on number 8 to be able to have symmetry between those 2 centrals without having a very wide crown on number 9 and creating a nice midline. So Michael starts designing from outside inside, like reverse engineering. So here, I like to use feldspathic ceramics. As I said, it's my material of choice for veneers, okay? But when I have a difference on the shape of the preparation and the shade of the preparation, sometimes I need a more opaque material, like in this case, an opaque zirconia material, to block out that discolored tooth and that's what it's called the rapid layer technology. We've done a lot of research at Penn on this topic, and basically by bonding feldspathic to zirconia framework, you have a very high success rate and few percentage of chipping. So here, what I want to show you is that when you have a very discolored tooth and the shape of that prep is very different from the contralateral, when you use a very translucent material, that can be counterproductive. So here I like to use a coping to make a very anatomical zirconia coping, and then two veneers on top with the VITA Trilux Forte. So this is the situation. On the left, a nice tooth prepped for a veneer, and on the right, an endo-treated tooth that has had a crown before, that of course the size of the preparation is smaller and it doesn't have a natural color. So here we create this custom or personalized coping in opaque zirconia, and then the two veneers from VITA Trilux Forte on top that will provide us that final aesthetic outcome. So as I said, we will make a webinar session fully on zirconia, but Dr. Blatt's main work over the last more than 20 years in studying bonding to zirconia shows that we can bond without a problem to zirconium oxide if we follow what he published as the APC concept. As we know, the oxide is not an etchable material, it's not sensitive to the hydrofluoric acid, so we need to change that treatment to air particle abrasion with aluminum oxide of 50 microns. Okay, once we do that step, then we need to apply a specific primer that contains MDP. Okay, this MDP will have the ability to bond to this oxide, whether it's zirconium oxide or titanium oxide. We've talked about that also when we talk about the Ti bases. But your conventional xylene won't do the job. And then we need to use, of course, a resin cement system. In this case, we use the Conejo V5. So here we have the coping. After air particle abrasion, we apply the ceramic primer plus that has the MDP. Then on the feldspathic veneer, we do the hydrofluoric acid etching for 1 minute, as I showed you before, and then apply the silane coupling agent. In this case, with Conejo V5, the ceramic primer plus has both elements, conventional silane and MDP for the side of the zirconia restoration. And then we apply the resin cement in the intaglio part of the veneer, and then we can do an extraoral cementation, assuring that we remove all the excess of the resin cement. And the photo on the right is a very nice photo because we want to make sure that every time we deliver a restoration in the patient's mouth, when we bond to a tooth, we want to make sure to see excess of cement flowing around 360 degrees following the margin to assure that that interface is as sealed as possible. Sometimes we think that no cement or less cement is better, but we really want to have that margin as sealed as possible. So you can see here a very nice aesthetic outcome. These are VITA Trilux Forte veneers, one bonded to the tooth and one bonded extraorally to this custom zirconia coping. This is not made by me, this is made by Michael Bergler with the same material, but what I want to show here is as clinicians to be honest and to understand our limitations. Maybe this was not such a straightforward case for me, and sharing with Michael, with a master ceramist, but giving my input on the materials and what I like from feldspathic ceramics was something that at the end was a very nice result for the patient. Okay, and just to finish this subtopic on bonding to zirconia, nowadays what we have are universal resin cements, and most of them have MDP inside the cement, so we don't need to apply an additional MDP or primer, and our research is showing in the early stages that this is something that could work as well. So some of these self-adhesive resin cements like Conejo SA Universal provide same short-term shared bond strength values than the gold standard multi-step resin cement system. So it's pretty nice to see how technology is advancing on the side of adhesive dentistry and resin cements to be able to provide good bonding to zirconia in a maybe quicker workflow. Okay, and I don't want to be sound that I want to bond everything with zirconia. And this literature review we did, we conclude that conventional PFC crowns and FDPs, we can use conventional cementation methods if we have retention and resistance forms. But if we want to start using the oxides like titanium oxide, zirconium oxide with tie bases and zirconia implant crowns, or less invasive preparation designs like overlays, wherever you want to use zirconia, but in a less invasive approach, not to create a full coverage crown, we do need to go through the APC concept, or make sure that your universal cement has the MDP component within the cement. Okay, so I'm going to leave now the feldspathic ceramic aside, and now I would like to start talking about zirconia, about lithium silicate ceramics. Okay, as we know, lithium disilicate was the first material from this group to be in the market with very high success rates, perhaps not with the highest aesthetic outcomes for some clinicians or for some patients. And then industry started to move forward, and then the zirconia reinforced silicate ceramic was created. Basically, VITA supremity in a pre-crystallized phase, or Celtra-Duo in a fully crystallized phase, which we found in our research that having a fully crystallized material to mill might not be the best idea for the material, because the material will suffer more. So we've been using VITA supremity PC, which is a zirconia reinforced silicate ceramic, and these materials come into different levels of translucency. We have the conventional translucent and the high translucent. So this is nice because, as you saw in the last case, maybe sometimes we want to have a little less translucency, which with feldspathic ceramics is not possible. It's too translucent. There's a lot of glass in there. So with this type of material, we have this flexibility between translucent and high translucent. And in the biggest percentage of the cases, I go with actually the translucent. Okay, so this is a case, let's say moderate complexity case, endo-treated teeth, so I can prep them very symmetric. Many of the mistakes I see on the preparation of these central incisors is that in the mesial and distal surface, we don't go subgingival 0.5 millimeters, so then we don't create a nice vertical running room for the technician or for the clinician who is designing the restoration to provide a nice support for those restorations. So here I do the same technique. I select the shade at the beginning of the appointment. I select the shade again after I finish my preps, just to have that second reference, and then work on my provisional, and then send this out to a master dental technician. So this case, I send it to my friend Telmo Santos in Belo Horizonte, Brazil, which I work a lot with him and we collaborate. And then Telmo takes over, and he goes with the design and milling and finishing of the supremity. Just as a quick note, remember that with supremity, we can work with a monolithic version, just with stain and glaze with the VITA Accent Plus, or here Telmo did a micro veneering of that surface with the VM11 ceramic. So we have those two options, and then we could also center this in the CEREC Spitfire if we are a clinician doing CEREC dentistry. So here, when I see these type of cases that are more challenging with a very difficult color, I don't try to solve it myself. I send it to a master ceramist. Okay, so Telmo here nails the shade with the information that I send him. Remember that the VITA Easy Shade provides also with a mobile assist app, very valuable information for the technician. Telmo is all the way down in Brazil, in Belo Horizonte. I'm in Philadelphia. So I just send the files, send the photos, send the information from the Easy Shade, and with that, we do a quick team viewer, and that's what he sends me, as you can see here. So this is a nice material and has also that flexibility to work as just monolithic stain and glazed or as partially veneered. And Telmo and I got to publish this back in 2019, already 2 years ago. So now I want to start moving to more complicated situations and at least share our experience. And this, we just published this at the Compendium magazine for April. You'll see it there. It's what Telmo called the reshape concept, and basically it's a technique to clone texture, but respecting some of the guidelines that the clinician wants on the restorations when we design. I think that we as clinicians know better the patient because we pack the cord, we can feel how that tissue is being displaced. We want to have certain pressure in certain areas, and if the technician is just working with a resin printed model or a stone model, he doesn't have that information. So for me, being able to start the design, making some specific determinations, but also giving him the difficult part, having him go and reshape that initial design that I do. I think it's the best combination from both sides. So here we have a very challenging situation, a patient with sequela of periodontal disease and loss of soft tissue, and of course, huge diastemas. Severe discoloration due to the fluorosis, patient disagreeing on soft tissue grafting, ortho, or even implant therapy. So many times my message here is that more is less and less is more. Keeping it simple, but doing high quality prosthetic dentistry would be many times a really good solution. Not only going interdisciplinary, taking years solving a case through ortho and surgery and soft grafting. Many times I see those cases not finishing that better than if we go with a clean prosthetic approach. So our facially driven protocol is something we do every case, as you can see here with the DSD app. That's something that I do as a clinician very quickly, and this gives me a good sense of space distribution. Then I print that digital wax-up, make a silicone index, make it place it as a mock-up, as a prep guide, and then I start designing. Here I prep 2 crowns and 4 veneers, and here we want to mark the margins. I'm the clinician, I'm marking the margin, but also I'm designing where I want to have the support on the soft tissue, where I would like to have the start of that proximal contact point to make sure that I'm not having a black triangle in such a difficult case. And then I share these, that's the technique of reshape. I use CEREC in lab, and then I'm able to share these to Telmo, who will be working on exocad, which has the ability to import natural tooth libraries, which I cannot do in CEREC and in lab. So this way, we both provide the knowledge that we have from the clinical side, from the technical side, for the better outcome. So here you can see the transition from what I send on exocad to what I send in InLab, what he receives and opens in exocad, and then he's going to basically imprint that library of natural teeth to that facial surface to recreate the most natural surface possible in that situation. So I'm happy to have now the publication next month. I already have the PDF, so whoever is interested, please look for me on my social media in Instagram or my email that I will share at the end, and I'll be happy to share you that. So you can see on the right side that the most cervical part of the restorations are not modified. That's what I want to have as a clinician for supporting the papilla, for moving the midline slightly, or where I want the contact point to start in relation with the bone. And then Telmo does the nice work, and this is also another case with supremity done very successfully, not as a clinician CEREC dentist, but scanning and sending this to Brazil and having Telmo work on that final restorations in the exocad software, incorporating the natural texture from those libraries. So that's what we call the reshape concept, combining the design and the guidelines that the clinician wants in the digital workflow, and him with the final texture and shape of the final restorations. Okay, so once we leave supremity here, I would like to move forward and talk about VITA Ambria. So VITA Ambria is, I would say, the latest material from VITA Sand Fabric. And what's Ambria? It's basically a zirconia reinforced lithium disilicate glass ceramic. Okay, this is a lithium disilicate, like many others lithium disilicates you see in the market, but as a VITA Sand Fabric product, it's a material very focused on high aesthetics, on color reproduction with certain particularities that will provide you that extra aesthetic outcome. Okay, what for? For the production of restorations, whatever you want, a single unit, call it veneer, inlay, onlay, overlay, and also 3-unit anterior fixed dental prosthesis. And it's very important to understand that I would keep it for the anterior segment, and VITA says up to the second premolar. So it's a material that if you want to use it for fixed dental prosthesis, never involve the molar region. I would use it more for the anterior sextant. Okay, and the particularity of this material is that it has a press system. Okay, so it includes the pellets in the 2 levels of translucency, as I was talking, as supremity in T and in HT. So in general, I would go with the T shade. If I have very thin veneers on very nice color of abutment teeth, then there I would say that the HT would be a nice option. Also, if I'm doing let's say an inlay, onlay, and the depth of the preparation has a nice dentin color, the HT will blend really nice in this type of partial coverage restoration. So Ambria is a full system with a muffle, with the investment material, the liquid, and everything that you need from the lab side to create the material. Okay, so here we have the possibility of working, as I said before, with the pressing technique and just applying stain. Okay, and also you can do what we call micro veneering or partial veneering, and that would be indicated for or recommended for the translucent pellet. Okay, if you want to do partial veneering over the translucent pellet, you will be getting the best outcome. So here explains you from the VITA website where they recommend one or the other. I just share you my personal, let's say, expertise and experience of the material where I use one or the other. So as I said before, for single units, you can use it in any clinical situation. Of course, for posterior crowns, first, second molars, anterior crowns as well. And what we do more now is partial coverage restorations. So as a laboratory technician, having the ability to design in the software and then mill a wax pattern makes the pressing technique very, very fast also, and also very economic. So I think that pressing, when combined with digital technologies, it's a great tool. It's a great workflow. It's nothing that I would like to use as a clinician, but as a laboratory technician or owner, it's a great workflow. And the nice thing is that VITA came out also with a brand new ceramic system. It's the VITA Lumix AC, and as you see in the photo in the middle, it has the particularity that you can apply it to basically all the ceramic substructures that we have in the market. We can use it over the feldspathic ceramics. We can use it over any type of silicate ceramic and lithium disilicates, and also to zirconia. So one system that it's very versatile because you can use it on different substructures. And the nice thing about this, I always tell the young technicians, is that the more you use one ceramic, the better you become with it. You get more training, expertise, tips and tricks, and here you can apply them with multiple substructures. So this is a case I would like to show, And this was done with one of my students at the university, an international student. He came with this case, and after doing the initial analysis, we see these non-carious cervical lesions on the maxillary teeth and some wear patterns on the incisal edges and occlusal surfaces of the lower posteriors as well. And many times we see these type of patients, maybe female patients in their early 50s, that they are not happy with their aesthetics, and what they are looking is basically for a rejuvenation of their smile, right? But in many clinical situations, I feel bad of preparing 28 restorations and removing a lot of healthy enamel in some areas that are not so aesthetic and so drastic. So it makes it more challenging actually when you are going to focus to a limited number of restorations, and that's basically a reality day to day. Many times the patient is looking for 6 anteriors to improve that segment of their smile, and we really need to try to blend to the remaining teeth, but trying to improve regarding shape, regarding texture, and of course shade as well. So here I always try to make and have a conversation with the patient before we start on shade selection. What is the patient looking for? Is this something that you want to improve the shade but keeping it in a tone that we can blend it successfully with the rest of the teeth that are not going to be prepped? Or is this more of a full mouth approach where patient is ready for a bleach shade and we don't have to match anything, right? At that point, that's very simple. It's very straightforward, but I really enjoy doing this type of daily cases when we do, let's say, 6 interiors like in this one. And we need to understand that depending on the thickness of the restoration, we are not able to go more than 4 tones. If we have a high translucent material like Ambria HT in less than 0.5. That's why maybe the T pellet would be a safer choice for this situation. So as our protocol goes, we scan every single case. We don't use alginate impressions anymore. We analyze the occlusion, we analyze the posterior support that we have, we talk to the patient to see where is the source of these type of non-carious cervical lesions, in this case being a combination, not necessarily it's only attrition, or not necessarily it's only abstraction. Sometimes we have a multifactorial cause of these non-carious cervical lesions, but it's important to observe the whole mouth. Don't go to a tunnel vision focusing on just the aesthetic concerns of the patient, so we make sure that we're going to be successful on the long term. So in this case, we evaluate and we can stay on MIP. We don't need to modify that position, and then we go with a digital wax. Of these, we do it at pen. This is done by Suan, one of our dental technicians, and then we will be 3D printing this model, and then we will be using it as a mock-up and of course as a prep guide. So once we do the preparations, we go ahead and make the final scan. And you can see here the preps. We prep tooth 6 to 11. We use a double cord technique using a 000 cord first and a double zero cord second, which we will remove, dry, and then go ahead and make the intraoral scan. In my last webinar, I showed the burr block that Dr. Blatz and I developed for Brasler, which is focused for CAD/CAM restorations, and it's very useful for any type of clinical situation, whether it's anterior and posterior crowns, veneers, inlays, onlays. Today, I don't think I have the slides of the burr block, but that's what we use for these type of restorations. Remember, if we want to go for partial coverage restorations, we want to make sure that we keep as much enamel as possible and just remove tooth structure in areas that we need to create space for the ceramic material. But if we are lengthening the teeth, if we are looking to replace that incisal edge position where ideally it was, we don't need to remove much of that surface, basically just soften that transition from the incisal edge to the facial aspect of the preparation. What is very important is to prep the elbow of the veneer, and it's exactly this area here where the proximal surface meets the cervical part of the margin. Make sure that we pack the 000 cord and prep that elbow of the prep as palatal as possible, so we provide, in this case, Telmo, a nice possibility of having an emergence profile and being able to close any of those black triangles. If we stay too facially in those situations, maybe there is no room for the ceramist to close that, and we can finish with a black triangle. So in this case, I talked to Telmo, and we had shared some VITA Ambria material last time we met in Chicago midwinter, thanks to the team of VITA North America. And I said, when I find a case that I want to use the material, I'll let you know. And then it came this case where I see that I have a patient with certain types of parafunctions, so I need a strong material. Maybe the feldspathic ceramic could be too translucent for the shade of this patient, where we don't want to go to something too bright, but keeping it as an enhancement on the shade, but keeping it natural as well. And then that we want to bond as well. So the possibility of VITA Ambria came very good for this clinical situation. So I send the files, I send the scans to Telmo, and then what he does is that he starts designing in InLab or in ExoCAD, and then he's going to be milling from a catwalk's disc these patterns. Okay, so once he mills that from the catwalk's disc, then he's going to go ahead and do the spruing and the investment, and then here we use the VITA Ambria T pellet for pressing these type of restorations. So I know probably many of you doing lab know all the details on this, but it's very important, the proper angulation as we place the pattern inside inside the muffle system. I took these screenshots from the VITA Ambria PDF. You can just go to the VITA Tanfabric website and download it. It's in different languages. You have different types of PDFs, but this is something important to make sure that you have a clean final restoration with no bubbles, that you have everything, the margins capture exactly what you wanted. Today I don't want to go too much on the lab side of this. We're talking more of that integration between the clinician and the technician, and the discussion on how to select the material and why we select the material. So as I said here, I like to use the T, not the HT, because the shade is not ideal, but we're starting with, and this is a very nice and clean result after pressing. These photos were taken by Telmo in Belo Horizonte, and then he did, for this case, he did two sets of restorations for me, trying to explain the two different possibilities. So what you have on the left side is what we call the micro veneering. He presses and then he adds a little bit of ceramic on the incisal third and the proximal facial aspects to try to get that additional touch of naturality in these situations. So this will be more of a high-end restoration, what we see on the left. And then on the right, this is the material with the technique of pressing and staining and glazing as a monolithic solution, which is also very reliable. It's a very strong material. As we know, lithium disilicate is very strong. This is a lithium disilicate, and we can also etch it with hydrofluoric acid, as I'll show you in a minute, and bond it. So it's a very safe material to use both in the anteriors and the posteriors. So here I'm showcasing both possibilities, the microveneering or the stain and glaze technique, as you see in the photo of the right side. So then I received the package, and then we go ahead and do the try-in. And it's very important at this moment to have worked with the patient through those 2 weeks of the best oral hygiene of her life through this process. Why? Because we want to make sure that we have no inflammation at all, so we can optimize the quality of our adhesive cementation protocols. I like to use the Panavia V5 resin cement system. There are many good solutions in the market. What is very important is never mix components between different cement systems, okay? We don't know the chemistry of all of them, how they act or interact, so just always keep it within one system. Here, for anterior restorations, I think that it's mandatory to have a resin cement system that has try-in pastes, okay? So what you see here, it's a try-in paste, it's a clear try-in, and I always start with the clear one, okay? If I like it, then I go with the clear cement. If I place the clear and then perhaps I feel that I need to make a slight modification, maybe a little bit of more of chroma, then I would go and try in again after washing the try-in paste with, let's say, an A2 universal try-in resin cement. From my experience, I feel that having opaque resin cements behind nice ceramic materials like ambria is like reducing those high aesthetic properties from the material. So that's what I'm saying, that shade selection before starting the procedure is very important. Shade selection immediately after finishing the preparation, so we know exactly what are we going to be dealing with, will help us select between translucent or the high translucent version, and of course be as precise as possible on the value, because at the end that's exactly what we can be more critical of, the gray scale, the gray scale, exactly how bright or how dark a restoration would look. So this is a lithium disilicate ceramic, VITA ambria, so we need to apply hydrofluoric acid etching, okay? Here, as different than the feldspathic ceramic group, we have less glassy matrix and more crystalline phase. That's why this material is stronger. So we also need less time of hydrofluoric acid etching. So 20 seconds is okay, is sufficient time to etch the intaglio surface of the VITA ambria restorations, okay? You want to make sure that you have that complete intaglio surface covered by the hydrofluoric acid etching, but you place it in a way that the acid is not going over the proximal surfaces or the facial, so you don't lose that final glaze or polish ability or polish surface, okay? Then after washing and drying, ultrasonic cleaning with alcohol is always a great way. Also, another possibility would be application of a phosphoric acid. As many literature shows, for lithium disilicate ceramics, this technique is beneficial to remove any excess. And then we go ahead and apply a conventional xylene, okay? Here, in this case, as I said before, we use the ceramic primer plus because it's a xylene also, but you can use a conventional xylene for this VITA ambria material, okay? Once you place the xylene, you don't want to let that restoration get contaminated. You don't want to get that restoration get dirty or wet. It's ready to the next step, which would be the final adhesive cementation. As I said before, when I was showing the first case with the porcelain laminate veneers, the feldspathic ceramics, we want to use a rubber dam isolation. We want to work during the time of provisionalization on the hygiene of the patient, prescribing high percentage of chlorhexidine during 15 days. So that will help us reduce the amount of bleeding that we have, and then we can place the rubber dam and start cementing 2 restorations at the time. That's what we do, starting with the centrals, then going with the laterals, and then going with the canites. So we apply the same cement as we did with the try-in, which is in this case the clear, and it's very important to have the full intaglio surface covered with cement. I'm not saying that you need to put excess of cement that goes around all the entire restoration, but you need to make sure that it's very well distributed within the intaglio surface. So when you place the restoration, you can have a nice flow of excess around all the entire margin, and that's what will assure us that we have a nice seal of that restoration. So this is the before on the left, this is the final on the right side, and it's really nice to see what we were talking about, this possibility of rejuvenation, enhancing the smile, enhancing the aesthetic on the anterior teeth without having to do a full mouth rehabilitation and going to an extreme bleach or toilet white shade. So these are the type of cases that we really enjoy doing, because we improve the aesthetics, but we keep our focus or our way of doing dentistry in a more conservative approach or manner. So this is a VITA Ambria. As I said before, you guys will feel very confident with it. It's a new lithium disilicate, and it has very nice aesthetic properties, and in combination with the new ceramic, which has a very small grain size and very nice aesthetic outcomes as well. In the hands of a master like Telmo, you can see very nice looking ceramic restorations. And just to finish, remember that no matter how strong the material is, how good and confident we are on our adhesive cementation process, when the patient is sleeping, they are not aware, and they can affect and chip any type of restorations or natural tooth structure as well. So for us, as we are diligent on making the pre-op scan to start planning with the DSD app, and we're diligent on making that final digital impression, we immediately, after we do the delivery of the restorations, go for a final third intraoral scan of the restorations. Once they have been cemented, we go ahead and design, and at this moment we 3D print these occlusal night guards, making sure that we provide at least 3 millimeters of thickness, and then we can have nice centric contact points on the posterior teeth, and we can provide also a nice desocclusion with the design of the night guard in the anterior teeth, and this will help us maintain this for longer. So my conclusions for today, before we go to any Q&A, Jim, is basically understand that silica and oxide-based ceramics provide aesthetics, but rely on proper case selection and handling. Feldspathic ceramics, we need to prep very diligently, we need to mill very carefully, and we need to bond as well. We have these type of lithium disilicate ceramics that we know they are stronger because of their inherent higher percentage of crystalline phase. Okay, so these materials, we can etch them as well, we can bond them, and that will also reinforce the material. And of course, newer formulations at the beginning, we need to be cautious, but in this case, we're talking about a formulation that has been proven for many years, so we feel confident about using VITA Ambria. So also, I hope that this quick, let's say, summary, going from the resin matrix ceramics to the silicate ceramics, gives us a good foundation for our next webinar, where I would like to focus on zirconia nowadays with so much exciting options to use zirconia, whether it's partial coverage restorations or full mouth, all on X implant cases. So I expect to share all that knowledge or content and publications we've done through the years on zirconia very, very soon. Okay, so remember, make sure you scan, make sure you provide some protection for any type of restoration, even if we're talking about porcelain fused to metal, PFC, or any type of monolithic ceramic restorations. Okay, for those of you that didn't join my last webinar, I want to share these last 4 slides. As a conclusion, no matter how good the materials are, no matter how much research and development is in the material, we need to pay a lot of attention to the small details. That will make the final outcome better if we are very critical from our work, and not only from the clinical side, but also from the planning side of the treatment. No matter how much technology we start using in dentistry, we still work with our hands, so we need to continuously keep challenging ourselves and improving our hand skills. Sometimes I try to mill very thin veneers and try to remove that screw without touching that margin, or doing the same with zirconia and working zirconia in the pre-sinter situation, which are challenging for me. So always try to keep getting that training on your hand skills, which is fundamental for the clinical success. Also, I didn't emphasize today, but I will talk about this, and we did talk last webinar on the importance of having specific material instruments. We need to have instruments for hybrid ceramic, for silicate ceramic, for PMMA, for zirconia, to get the best properties out of those materials. Many times we see patients coming with fracture restorations, and we really don't know the exact reason, but when we ask, patient says, yeah, the restoration was high, they were removing material, and we don't know exactly what grade of diamond they were using, if they were using water or no, if they polished that surface after making the modification. So we need to follow the guidelines of each material, but also have the specific instruments not to harm or affect negatively that material or that restoration. Okay, and my last conclusion would be always deliver what makes you proud. Okay, many times I see colleagues saying, well, no, patient was pretty happy and we just deliver the restorations. Yeah, but sometimes we have patients with very low expectations, right? So it's not wrong to take a step back, take a step aside, modify, enhance, fine tune, and then deliver on a second or third appointment. I think that if we're looking for these restorations to last 10 or more years, if I took 1, 2 days or weeks more to finish the case, it's not going to be significant at the end of the day. So I try to always deliver what really makes you proud. So I always like to share my contacts. This is my email, jconejo@upenn.edu. Also I have this Instagram profile where I share a lot of dentistry. It's only about dentistry. We share clinical tips. We share some links to our webinars, or also links to our publications. So this is a good way as well to keep in contact. If there's any question with the material, if there's any situation you would like to hear, at least one more opinion, please don't hesitate. Just shoot me a text there or an email, and I'll be happy to get back to you and provide with my suggestion or my experience with a specific material or procedure. Okay, so Jim, once again, thanks a lot for having me. It's very exciting to always talk about new materials, and I'm excited to have you here and see the case we did. Thanks a lot to Telmo. He was going to join us. I'm not sure if he was able to do it, but also if there's any questions from the pure technical side, I'll be happy to get you guys in contact with Telmo and keep this collaboration, this mutual collaboration between peers going.
All right, Dr. Conejo, that was fantastic. A lot of great information. I'm sure we've got a lot of questions, which it looks like we do, and we will get to those here in a second. So I want to let everyone know again that the CE, that you will be receiving an email after this, and then just answer that email, and we'll get you those credits, whether you need a letter or through MBC or whatever the case may be, to help you out on that. It was recorded, so Dr. Conejo he's online now, for this webinar, and you can come visit us at the website and look at that recording. And then those are posted on our website, but also on like the YouTube and all the Facebook and social medias as well. So please come visit us at that. You can always also give us here at the VITA North America, the headquarters in California. You can always give the help desk a phone call if you have any follow-up questions. Then beyond this, we've got about looks like 10, 12 questions here. So without delay, we'll try to get to them as soon as possible. Also, you can get in touch with many of our reps as well. Those are scattered around the U.S. and Canada. If you're visiting us from Canada, we have quite a few people, Dr. Conejo from Canada, visiting us on your webinar as well. And then we also remind everyone that Dr. Conejo has several webinars still scheduled for the rest of this year. So, you know, May 11th, June 22nd, August 15th, September. And plus, we'll be probably adding more as the year goes through. And then if you want to see a full list of America's courses, webinars, anything we do, you can visit us there at vitanorthamerica.com/courses. So before we go with questions, we'll get on those. So we have a question from William. And on Ambria, do you only bond, or do you also conventionally cement?
Yeah, that's a great question, William, because it's a clinical reality. Maybe you're working on a posterior tooth that has one of the proximal surfaces perhaps slightly subgingival, and it's very complicated to really create an ideal rubber dam isolation, and then having a conventional cementation would have a lot of sense as well. So the great thing about Ambria, as I was saying, lithium disilicate is a strong material. So if you bond it, as I show for anteriors, which is much easier, you will reinforce it, but the material is sufficiently strong to go with conventional cementation for those situations. I would say let's not get too lazy and just do conventional cementation all the time, but I really understand your question and agree with you. For some situations, that's the best clinical judgment, and we have that option in the material. So when I tell my students or residents, well, if I don't see rubber dam, we are not delivering. Rubber dam is there. So we got to also, work on that for making that procedure quicker and more streamlined as well, the adhesive cementation. But if the clinical situation makes it too difficult, or maybe the conventional cementation would be the best way to go, that's also a great possibility with this material.
All right, thank you very much. And for those of you who are asking, the Ambria, once it's tempered, it's about 550 megapascals. So it is, as Dr. Conejo mentioned, it's certainly strong enough. So we have another question from Saba Dental Lab. When trying the mock-up, if the mock-up is in some areas are lingual, we can't use the mock-up till we trim the teeth in that area. So I'm not sure if that makes sense or not for that.
Yeah, sure.
So what is your strategy in this type of case?
Yeah, I really understand that question. I do a lot of my lab, and if the mock-up is not highly detailed, is not that useful. We just think that it's putting the bisacryl and scanning it that quickly, but then your stitching is not great, your biocopy is not going, the difference on the cervical from what you have in bisacryl or where you have your initial scan is too different. So yes, we need to try to have the best putty matrix. I invest time doing my putty matrix, relining it, and then cutting it in a way that as soon as I put it in the patient's mouth, the same matrix cuts the excess, and then with the Explorer, very gently, I can remove that excess. But then there comes the second step, which is going with the ultra fine burr that we have in the block, in the burr block, which is this yellow diamond, and I will go around the cervical areas and the incisal or palatal edges, as you are saying, so we don't have any excess, and then we go and do the scan for the biocopy of the mock-up at that situation. And when we're doing full coverage and we have the space, I want to work the occlusion on that bisacryl and scan it and make sure that we can copy that for the final restoration. So we have less work to do, both the clinical and lab side, to get that occlusion ideal as possible. But a halfway mock-up, it doesn't really help. I think that a really well finished mock-up, it has a lot of value, but maybe working more on the matrix is something that is very helpful for us, for clinicians, to get a better, cleaner result on the mock-up.
All right. So, you know, it's great that you discussed the night guard, because I think it is important to have in certain patient cases at night that they have a night guard to protect what they've spent a great deal amount of money and cosmetically made look great to have. So we do have a question about the night guard. Night guard, you said the anterior veneers, there should be no contact with the opposing in the anteriors, and that's a question. So he's asking, should there not be any contact with the opposing in the anteriors for a night guard?
Well, we would need to make a full session. If we go very heavy on theory on night guard and occlusal schemes, and I think, Jim, that the best night guard is the one that the patient uses the most. I was trained with neurologists on my PROS program, and it was very difficult to really create what they really wanted regarding number of contact points and locations and these occlusions, and it was so rigid that the patient hated it. So yeah. I think it's a balance. I want to have centric points of occlusion in the posterior teeth that are actually oriented to those posterior teeth to take that heavy load. And then I want to have softer contacts, same as I do without the night guard, with the night guard, and a very nice, soft, let's say, palatine surface of the night guard. So if there's any protrusive movements, there's a mutually protected occlusion where we are not having interference in the posterior teeth. Not a very steep anterior guidance either, that could be stressful for the veneers or even for the teeth. And in many times when this is designed that way, you can see slight mobility of the anterior teeth as well. So strong centric occlusal contacts on the posteriors, try to get 10 contact points between the bicuspids and the molars, slightly less contact in the anteriors, and a nice design that is not so steep, but we can have this anterior guidance with the night guard. And that's something that I would say works pretty well for us. I think that it's very important, if you're doing night guards from an intraoral scan, to pay close attention to the proximal surfaces of that scan, the embrasures, because that's exactly where the night guard gets the retention. I don't really change any of the parameters when I'm designing the night guard, but I make sure that I scan very well the embrasures, the proximal surface, so the night guard has a nice intimate contact in those areas, and then it has a nice retention without having to create too much stress to the teeth as well. Maybe for one of the next sessions, we can I can make a set of slides of the elaboration of the night guard, and how we get to that point where we found a nice balance between the parameters and the intraoral fit of the night guard. The night guard needs to be comfortable. It needs to be like that feeling when you get home and you put some Crocs on, or your sandals, or a comfortable shoe. That's what we need to get on the fit of an eye guard.
All right. So kind of backtrack on the early part of it. You were talking about hydrofluoric acid etching ceramics glass. Is there a point in which you can over etch, and if you do, what happens? What are the pitfalls of over etching glass ceramic?
Well, yeah. So for hybrid ceramics, let's start from the hybrid ceramics. The publication that I showed last webinar on JPD on bonding to enamic, we tested 60 seconds, we tested 120 seconds, and the bond strength and the strength of the material was the same. So let's say you could go from 60 to 120, but I wouldn't go more than 2 minutes on the hybrid ceramic, and that would apply as well for the feldspathic ceramics. For VITA, the numbers are 1 minute, right, Jim? It's 1 minute for enamic.
Yeah, 60 seconds, and 20 seconds for supremity. Yeah.
Yeah, exactly. So I would say you could be in that range between 60 seconds and 120 seconds, 1 to 2 minutes. But there's really no need to take longer. It all summarizes on the attention to detail, right? We gotta have a timer. We gotta be ready. Place the hydrofluoric acid, hit on the timer, stay there. Once it's ready, start with the spray, water, air, removing it quickly, and then move to the next one. Many times, if you have, I don't know, 10 or 12 and you want to do all at the same time, I'm sure the time of etching of the last one is going to be different than the first one. So make small groups, but try to keep it within those ranges. And then with the, as you were saying, Jim, with supremity or lithium disilicates, why 20 seconds? Because there's less glassy matrix, so there's no need to etch for a longer period of time. And then, of course, zirconias, they are not etchable, right? We will go in depth on in a later webinar, but that we need to air particle abrade.
All right, I think you kind of answered this during the presentation, but someone had a question: is the MDP primer the only material that can be used for zirconia? But I think you mentioned Panavia SA Universal is something that might be an alternative.
Yeah, well, actually, the Panavia SA Universal has MDP, but inside the cement. MDP nowadays is the most successful monomer for bonding to zirconia. There are other options, okay, but in general, I would say that MDP is the one that has been more studied. Dr. Matthias Kern from Kiel University in Germany, the most northern university in Germany, has published data on bonding to zirconia with MDP for over 20 years. So it's something that doesn't have any discussion. Are there other things available? Yes, there are, but what we used based on this research, at least from my experience for the last 6 years, Dr. Blatt's probably 20 or more, is with MDP.
All right. Research is important, so stick with what works and has been proven. Yeah. So we have a question on more shade related, but it often comes up during your webinars. Is you have the end result, looking at the end shade, what you want. So if it's a A1 is what you've selected, the patient selected for the final outcome. If the prep shade is darker, how do you determine the lightness or the shade of the product so that when you're all done, it becomes an A1? How many shade levels of brightness do you go by?
Yes, there's a very classic article by Dr. Rosenstiel from Ohio State University, and he explained that in less than a millimeter, you have a limitation to go from, let's say, extreme situations, right? As I said before, from a C4 to a B1 in 0.7. It's not going to happen like all the time. Okay, what we need to understand is that we need material thickness to be able to manage those more extreme cases. So what I would say, Jim, that I do is that on my first appointment where I do shade selection, when I'm treatment planning and I see the patient's intention of the shade, that's one more item that I need to include in my discussion if I'm going for a veneer or prepless veneer or a full coverage restoration, if I'm going to be more invasive, right? So many times we just select the material, we select the shade after finishing the prep, and that's it. And that's where the mistake comes. But if we know that thickness is important when we have these extreme changes, then we want to assess that from the beginning. Then when we have these type of combination cases where you have, let's say, 2 crowns, 4 veneers, one is endo-treated and it's very dark, so I want to try to use a material that can help me enhance that color of the worst stump shade to use something more translucent overall, like feldspathic ceramic. So I would say it's a case-by-case decision, but if you are in a combination case, and let's say you have a moderate discoloration, let's say the Ambria T is a good option to mask up to certain amount. If it's extremist, I would go with the first generation zirconia with a nice sleeve, and then on top you can use something more translucent if you want. Feldspathics are great, but rely on that condition of the abutment tooth. So I would use the feldspathics for probably younger patients that once you prepped, the color of the stump is more ideal or not so far from what you're looking to get.
Yeah, this question is often asked, as you know, and maybe it's time to do another updated study. But for those who missed it, what was the name of the study that you referenced, where they talk about prep shade and ultimate finish shade? What was the name of that doctor that did the?
Yeah, it's Dr. Steven Rosenstiel. Dr. Rosenstiel, he's the director of the JPD. He has this huge book in fixed pros, and if you send me a text, I can get it from PubMed and send you the PDF. But you know, not only in vitro studies always are the solution for the clinical dilemma, Jim. I think that trying to have homogeneous thickness on your anterior restorations is always very helpful. So if you try to be in a range of 0.8 to 1 millimeter in all of them, your final outcome is going to be better or easier to achieve if you have one veneer that is 0.3 and others that are 0.8 and a crown that is 1.2. When you have that type of salad scenario where it's very mixed up, then it's less predictable. So thinking about this situation during the preparation appointment, using your prep guide and checking the thickness, not only for creating the space for the material, but also thinking on the need of slightly mask, will help you a lot. And then if you use the VITA materials, of course, with the VITA shade guide, you don't have any risk of losing information when we jump from one shade system to another, which in other situations, that's one of the reasons, right? To be honest, you can use the VITA Classic if that's the VITA material that you have, if it's a block. When I have a challenging case, I always get my 3D Master out. When I have something that it's not so obvious, I go with the 3D Master because I know it's scientifically and I'm going to be assured I'm within the value.
So there's a comment by Mr. Felix Pages. He uses facial veneers with different values and tries them in, they have them in 0.5, 0.7, and 1 millimeter thicknesses. A comment by Mr. Pages.
Okay.
So we have another question on, does a finishing agent leave a cloudier glaze finish?
It's not cloudier. I think it's pearl, I would say. I think it's like thinner layer that penetrates very nicely and seals the restoration without losing the texture. And here maybe Jim, you can help me with this one. I just like how it looks. It looks like a natural tooth. It doesn't look over glossy.
Right, and that's what it's for, is an alternative to give you more of a natural matte finish that's more resembling a natural tooth gloss. Yeah, you're correct. And then how do you mill or press a veneer? And when you mill or press a veneer, do you polish, or do you always glaze? Or again, it's patient specific?
Yeah, polishing is always more important than glazing, I would say. But if you're doing one veneer on a number 10, even if you use a multi-chromatic block, for example, you might need to customize a little bit more that incisor edge and those mamelons. So that's where we need to stain and glaze. If I have a patient that has a lot of dentistry, a lot of PFM crowns, and you're making one, could you just polish it? Yes, of course. I want to be practical as well. If it's not in the aesthetic segment and aesthetics is not compromised, just polish is very good biologically as well, and for the ceramics. So only what I don't really like, and being very honest, is when clinicians just want to get very fast with chairside, and there are cases that you see that could be better if you customize with stain and glaze and you just go with a polish. I wouldn't do it that way.
All right, and then just a couple more questions. When you do have to block out a prep, is there a go-to material that you use to block out the prep before you scan it?
Before I scan?
Yeah.
Yeah.
Or do you block it after you scan, or probably not,
no,
right?
I actually like to mask with zirconia sleeves. I'm not a fan of using opaque resins, white resins that you place on top of the discolored tooth, and then you prep, and then there's like an area that it's more opaque than the other one. That I don't see any real benefit. As a prosthodontist, I like to do a lot of indirect, so I make this sleeve. And we got to remember that if we have an endo-treated teeth and it's discolored, it's not only the clinical crown or the part of the prep that we see, that root is also discolored. So zirconia can be milled in a very thin margin, and we can place that slightly subgingival, and zirconia in a very bright shade basically illuminates that soft tissue and actually reverses the umbrella effect of having that grayish around. So we'll be talking about zirconia and these details, but I think that maybe for a few cases those flowable opaque composites could help you. I honestly have better control with indirect zirconia sleeves. As I said, Ambria T or Supremity T can help you if you have sufficient thickness, 1 millimeter.
On your zirconia copings, how thin do you get for your sub framework, that coping that you're describing?
Yeah, don't get mad, Jim, but we get very thin. Yeah, you can go, if you have a good setup in your milling machine and everything is working well, you could go to 0.3 and then you hand polish that, and it's very, very thin.
All right. So I think he kind of answered the last two questions. One was on supremity. Do you mainly use a T or HD? But again, I think it's dependent on what's the underlying prep looking like, the tooth prep. But if you want to elaborate any more,
yeah,
that's
I
fine.
would say that I would go 60-70% more with T and probably 30% with HT. HT is nice for veneers in younger patients with more ideal clinical situations, or maybe partial coverage of the posteriors like inlays. It blends very nice for crowns, and in general I prefer the T. Sometimes we hear that translucency is overrated. I wouldn't say overrated, but it's something we gotta manage, because translucency, not well understood or managed, can hurt us as well.
All right. And then you kind of answered this already within your webinar, but there was a question about whether you print or mill your model casts. But you mentioned that you probably print them nowadays.
Yeah, we are printing nowadays. We were not the first one rushing into 3D printing, and I've discussed this before. But nowadays we are 3D printing with very good results.
All right. Well, I think we've taken enough of your time tonight, and I thank everyone that has joined us for the webinar with Dr. Conejo. Again, we have several more with Dr. Conejo and several others. So soon, as Dr. Conejo mentioned, we'll soon have in-person programs as well later this year, hopefully, depending on what area you're located in. But I really want to thank you, Dr. Conejo, for joining this, providing all the great information that you have tonight. Any last words that you want to convey to the people?
Yeah, sure. No, thanks a lot, Jim, for having me. It's always a very nice experience to share and discuss. And also, if any of the participants has any topic that you guys find that would be attractive to us to create a webinar, or at least go through this topic during one of the webinars, we're open for that. As you can see, we have four more dates already scheduled. So let us know, let the VITA North America team know, and we'll be happy to try to custom made these webinars for your specific needs. So thank you again, and have a great evening.
All right. Thank you, Dr. Conejo, and thank everyone that has joined us today. And this will conclude our VITA Learning webinar with Dr. Conejo. Have a good day wherever you may be.